Okay. Good morning, good afternoon, and good evening. Welcome, friends and colleagues from all around the world to this webinar series on public health, ethics, law, and human rights for the future of humanity. And it's wonderful that we now have an audience of about 850 people from 56 countries around the world participating in this conversation around the future of humanity. The webinar seems to have captured the mood of the moment, highlighting the mood of our times and the central load of ethics, law, and human rights at this time. And we've had a large number of practitioners, actually, for those who couldn't participate from Australia and other parts of the world, who actually could not participate today and will be recording the session today to share with other colleagues. We've also had the good wishes of many institutes of ethics, public health, law from around the world, such as the Hastings Center, the Quebec Center, the National Council for Bioethics, and numerous other ones, sending us our wishes, because I think what's been recognized that ethics, law, and human rights is not the business of only lawyers and ethicists, but it's a business of public health practitioners, policymakers, and all, because decisions are being made on our values and the choices we're making at that time. So thank you very much for all those institutes and their good wishes, and all the other scholars and practitioners who've given us the time. One local director of public health sent me an email to say, I'm very busy with COVID, but I'll prioritize this today because we need to collaborate much more with scholars, practitioners around the future of humanity. So it's my great pleasure to now invite Professor Maggie Ray, the President of the UK Faculty of Public Health, to kindly initiate this particular webinar series on behalf of all the different stakeholders who have provided reasons to do that. So welcome, Professor Maggie Ray. I know you've been busy working with ministers in these days, preparing for a possible lockdown tomorrow, and also you're supporting the public health workforce at that time. So thank you for joining us at this meeting on behalf of all the different stakeholders. Thank you.
Thank you so much, Farhang. Hello, everyone, and thank you for inviting me to open this very important seminar. I'm delighted that there has been interest from public health colleagues, ethic experts, legal experts, academics, and policymakers from around the world in this international series. The COVID-19 pandemic has further highlighted the fundamental importance of solidarity in improving and protecting the public's health. It has also highlighted the importance of justice, ethics, law, and human rights, and of course, health inequalities. The webinar series will provide an important platform to advance the discourse, scholarship, practice, and policy at this critical time for humankind and our health. My sincere thanks to Farhang, Larry, Michael, and all the other speakers who've been organised for today. I hope as delegates you have a really interesting seminar, you enjoy this, and this solidarity, this meeting today, will bring us all much closer together in our endeavours for human health. Thank you very much indeed, and passing back to you, Farhang. Thank you.
Thank you very much indeed, Maggie. I just want to go through a few housekeeping things for those people who may not be familiar. For those people from some countries, your internet may become unstable. There will be a recording of this, and we very much hope you can actually be part of this process. Please complete the poll on Zoom. This is a little button at the bottom. This is quite useful for us to know who is here at the moment, because we want an engagement process around this one. Please ask questions using the QA button, which you again can see at the button. There won't be time to answer all the questions, but we want to record them and again use this as a process to advance this discourse, scholarship, and importantly, practice and policy. And please use the hashtag public health ethics for those who are on social media. This is now live on YouTube and so on. And some people are also watching it on social media. I think the topic for this first seminar is around justice, similarity, and public health. And for me, thinking about this particular seminar, I was thinking, what is actually COVID telling us? What's it telling us about justice? What's it telling us about solidarity? And the thought which is crossing my mind is that COVID is not the only public health emergency we currently have. We have the climate emergency. We know from the work of Michael Marmot that social justice is almost like a pandemic, killing people on a grand scale. We had Ebola, we had SARS, after which we had numerous reports, writing reports as a wake-up call for us and humanity. And this again has been highlighted as a big moment in our history, as a wake-up call, as many scholars have said, and the need for social justice. But I'm just wondering that the solidarity trial for us developing more vaccines will not sort all this out. We've had numerous wake-up calls, and we need more than that. And as I highlighted editorial in the Lancet, we need to move from rhetoric to action and really hearing what is COVID really telling us. And I think today's seminar on solidarity and justice and the insights and the subsequent seminars are quite important in providing a framework around the knowledge and importantly around the actions we need to do together. It's a great pleasure to be able to have a lineup of some leading scholars who are supporting us through these particular webinars. And I'm delighted that our keynote speakers today will be firstly Professor Larry Gostin. I'm not going to go through huge biographies here because he's well known for us around the world, in Australia, in UK, in South Africa, because he doesn't, although his title is the director and the founder of the O'Neill Institute and the leader on global health and the national and global health and director of WHO, he's been friend to many of us around public health law as a leading and one of the most influential figures around global health law and public health law. His recent work around health or legal determinants of so are important for us all in public health around the world. In this week's Lancet, there was a review of his book, his most recent book. He's written many on foundations of global health and human rights, which was reviewed just this week in the Lancet. This is referred to as a textbook for students and so on, but I think it's more than that. It provides a marker for us all as students to answer the questions around what does global health with justice really mean and how can we achieve it? Because this is more important now than ever before if we're going to translate this in action. So very grateful to you, Professor Gostin, for joining us today, and the floor will now be yours to kindly share with us your insights. Thank you.
Thank you very much, Farhang. That's a lovely introduction, and thank you both to you and to Maggie for organizing this session. It's extraordinarily important. You know, in my work, particularly my book on global health law, I posit that there are really, you know, two major issues that are facing the world. One is global health and the other is justice. And while we tend to think of global health justice as a single concept, it's actually not. You can have global health without justice, and you can have justice without global health, but we need both. And so global health simply means ever increasing indicators in good health and longevity across a variety of factors. And by that measure, you know, we had been doing very well, and I'm going to be getting to that in a minute. Justice is just as important, but it means that you have to have a fair and equitable allocation of the good of human health distributed to everyone around the world, irrespective of their race, color, religion, socioeconomic status, or where they were born. And so you can have global health, a lot of increased indicators for health, but people are left behind. Or you can have a flat curve where we're not getting increasing global health outcomes, but it's more equitably distributed. We don't want either, we want both. And so let me take you to a little story about these two issues. Beginning in the millennium, in the year 2000, through to the Sustainable Development Goals of the United Nations, and now through COVID-19. What we've seen, and I'm going to take you now from the MDGs to the SDGs, before we got to COVID, is ever increasing outcomes. So people are living longer. We've reduced absolute poverty considerably. We've made great inroads in HIV, TB, malaria. Child and maternal deaths and underage 5 deaths have been improving. There have been fewer child marriages, more girls in education. So we've done fairly well. At the same time, it's very clear that up until COVID-19, that there was one overwhelming global narrative. And that overwhelming global narrative are for those left behind. In fact, the SDGs pledge not to leave anyone behind. But we've left a lot of people behind. The goods of health and longevity are very unevenly distributed, both among countries and within countries. And so we see vast disparities between higher and lower income countries. And whether it's a higher or lower income country, within those countries, we see vast inequities in the distribution of good health. Martin Luther King famously said that all inequality is unjust, but the greatest injustice are health inequalities. And we've seen enormous health inequalities everywhere on the globe based upon race, religion, culture, socioeconomic status, and the like, where we've had generations of people who have been hit very, very hard, while many in the upper income countries and within upper income groups within all countries doing extraordinarily well. And then came COVID-19. What COVID-19 has taught us is two things. One is that the absolute, seemingly inevitable increases in global health outcomes are actually being stopped or reversed. And so we're now seeing people being thrown back into poverty. We're seeing girls who are don't have an income and are being forced into child marriages or exploitation. We've seen girls being pushed out of education and educational opportunities. We've seen a series of crises around programs for HIV, TB, malaria. We've stalled on our polio eradication initiative. We've seen great harms in non-communicable diseases, cancer, heart disease, diabetes, and the like. In short, many of the wonderful gains that we've had are starting to reverse and reverse significantly. We had, even before COVID, a problem with vaccine hesitancy. We've seen measles outbreaks, But childhood vaccine programs, if you ask Gavi or anyone around the world, they will tell you are in grave jeopardy. In other words, COVID has caused nearly 1 million deaths worldwide, and those are the official reports, 200,000 in the United States, probably many more in the US and globally, of unreported cases. So we've seen a lot of death and disease and suffering from COVID-19. But what we don't see as vividly, but is absolutely true and has been true for almost all epidemics and outbreaks, is that deaths and suffering from other diseases, not related to the pandemic disease, increase and cause more deaths. We've seen lockdowns, which may be necessary to preserve COVID escalation. But at the same time, these lockdowns are fine for people in the upper income classes. If you've got a stocked fridge, if you've got reliable internet and computer, if you've got a job that allows you to work remotely, COVID has not been a vast disruption in your socioeconomic life. But if you've got to go to work on the front lines, an essential worker, or in sanitation, firefighting, hospital work, you're going to be put in jeopardy constantly. We've seen, particularly in the US, but also globally, many factors more COVID and non-COVID related deaths due to poverty, unemployment, eviction, loneliness, causing overdoses, dependence, alcohol, drug dependence, partner abuse. All of these things have occurred within COVID, and we don't have a good idea of what the excess mortality is, particularly based upon lockdowns. Do they cause more overall deaths than they save? We need these data, and we need them very, very badly. And so what COVID has shown us is that we've got a narrative of deepening injustice and also a reversal in global health outcomes, the worst possible a combination of factors that we could have. At the same time, in many ways, we've seen unparalleled global solidarity, scientist to scientist cooperation. For example, the COVAX facility of Gavi and WHO. But we've also seen unraveling of social solidarity. We've seen the World Health Organization put unconscionably, as the Secretary General of the UN, Guterres, said yesterday at the UN General Assembly, that it's unconscionable that the WHO should be put in the middle of a geopolitical struggle between the two world's great superpowers. It's probably the greatest embarrassment I've ever had as an American to see the President of the United States announce the US withdrawal from WHO. By law, he can't do this for a year. I hope by that time we will have a new president. And in any case, as the director of the World Health Organization Collaborating Center on National and Global Health Law, I've been discussing with key litigation partners about challenging that action. I want to end with just a paradigm of the equity problem we face. Many of us are looking forward to the time when we get back to normal. I don't believe that that's going to happen until the second or third quarter of 2021, probably not fully until well into 2022. COVID won't go away then, but what will happen is we'll learn to live with it. A combination of vaccines, natural immunity for people who have an immune memory from having SARS-CoV-2 infection, and much, much better treatments and public health interventions like testing, tracing, and social distancing, masking, and the like. But a key ingredient are vaccines. We now have an unprecedented global race for a vaccine. In many ways, that's good because we want healthy competition. And we've made enormous progress in terms of having 9 phase 3 vaccine candidates in phase 3 trials, many more in other human trials and preclinical trials. Many of us foresee that by 2021, we're going to have more than one vaccine, but we don't know the extent to which it'll be effective. It might be like an influenza vaccine with a 50% or more effectiveness rate. We think it may need 2 doses. And so the problem, the logistics of distributing this worldwide are simply staggering. So what do we do? What we do is we have to think of a strategy to ramp up production very, very quickly. We have to assure that our scientific agencies, like the European Medicines Agency and the US FDA, are rigorously scientific. And the most important thing is we need equitable distribution of the vaccine worldwide and globally. What will that look like? One of the things I'm looking at the United States is that our CDC is considering using race as one of several factors, including socioeconomic status, as a priority indicator for the vaccine. But we have a very conservative Supreme Court, soon to get more conservative with the tragic death of Ruth Ginsburg, a person I knew and deeply admired and loved. So whether or not we will have that ability to use race as an indicator is still up in question, but we're pushing for it. So we've got a lot of work ahead, my friends. We have to protect our cherished international institutions, particularly the World Health Organization in its vital role now to ensure global solidarity. We need to fight for equity and justice, and we need to start to reverse all of the harms that COVID has done, not just with COVID deaths, but with deaths from so many other causes, suffering from so many other causes, loneliness, isolation, mental distress from so many other causes, economic collapse. These are the things that we need to do. Now, going forward, we have 2 paths. We can take the path of global health with justice, with strong international organizations and global cooperation, or we can be nationalistic, populistic, my country first, me first. I hope that in the true tradition of public health ethics, what we will do is we will stress and amplify our sense of humanity, our sense of the future, our children, and that will require health for all with justice. And as Martin Luther King said, there's nothing more important for our civilization and for our global society than equality, equity, and justice. Thank you very much for your attention. I look forward to being with you for the rest of the hour.
Thank you very much indeed, Professor Gostin. That's very, very helpful. And I think one of the key issues, as you've highlighted, is to what extent we look inwards within our nations, and to what extent we look outwards to humanity. And that's one of the things which COVID is testing us at the moment around. I'm delighted to introduce our second keynote speaker, and for this series to highlight collaboration between practitioners, academics, policymakers, lawyers, ethicists, and others. It's important to have different perspectives. And I'm delighted and honored to actually welcome Professor Sir Michael Marmot, who doesn't need an introduction amongst us. As everyone knows, he's one of the leading figures around social determinants of health. He's director of the University College London Institute of Health Equity, past president of the World Medical Associations. And his work is internationally known. He read the WHO Commission on Social Determinants of Health. But he's not only a knight of the realm in the UK, I think he's a knight of the realm globally around social determinants of health and justice. I got in organizing this particular webinar series, I had an email from a Maori lady who's a public health activist in the rural area, a Maori lady, and she said to me that this is about social justice. Marmot is our man on justice. So I think he not only influences policy at global WHO level, but he works with individual citizens in fighting for global justice and fighting the organized efforts of misery at the moment. Thank you very much, Professor Margot.
Thank you. I have a very simple proposition, and that is the health of a society tells us something fundamental about how well that society is meeting the needs of its members. And health inequalities tells us something fundamental about inequalities in society. So if health has stopped improving and inequalities are getting bigger, it means society has stopped improving and inequalities in society are getting bigger. And that's really the theme. And it's consonant with what Larry Gostin just said. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. With COVID-19, the healthcare system is fundamental. But I'm not going to talk about the healthcare system. I'm going to talk about the conditions that made people sick. Just before the pandemic crashed upon us, I produced in England this report, Health Equity in England, the Marmot Review, 10 years on. After the WHO Commission on Social Determinants of Health, I'd been commissioned by the British government to do the Marmot Review in England. We published in 2010. And just February the 25th this year, I had a look at what had happened over the last 10 years. And my summary conclusion was, we have lost a decade, and it shows. In England, life expectancy had been improving about 1 year every 4 years for women and for men. And in 2010, there was a break in the curve, and the increase slowed dramatically. When we look internationally, the improvement in life expectancy in the UK was slower than in virtually every other rich country except Iceland and the United States. So the UK and the US, if you accept my proposition, society had stopped improving and inequalities in society were getting bigger. This is women, life expectancy for the least deprived 10% in every region of England. Life expectancy was improving and there was very little regional difference, some, but not huge. For the most deprived 10%, huge regional differences. Life expectancy was improving for women in London, but it was going down for every region outside London. If we look at the US now, this is life expectancy at 50 by deciles of income, by year of birth, from year of birth 1920 to year of birth 1950. For men, life expectancy in the poorest decile was improving a little bit. In the next decile of income, a bit more, bit more, bit more, bit more. So huge steepening of the gradient increase in inequalities. That's men. Women, life expectancy went down at age 50 for the poorest 10%, for the second poorest decile, for the third poorest decile. So both in the UK, in England, and in the US, life expectancy for the poorest women was going down. Inequalities in health were increasing, and overall health had stopped improving, or in the US case, had actually gone down. And if you accept my proposition, it means society was getting worse. What happened in the UK in 2010? Well, one thing the new government that was elected, the Conservative-led coalition government, said was, we will reduce public expenditure, or as I might put it, we will roll back the state. Public expenditure was 42% of gross domestic product in 2009-10, and they did indeed roll back the state. So it went to 35% by 2018-19. If we look at tax revenue as a percent of GDP for OECD countries, France, up here, 45, 46, 48%, Denmark, Belgium. So the UK was in the middle of the European range in 2009-10, and now we're below the OECD average. We are ahead of Estonia and, of course, ahead of the United States, which only spends about 25% of GDP in public expenditure. And if we look at what's happened in the US, the change in effective tax rates for the richest 400 between 1962 and 2018, the richest 400 Americans, their effective tax rate went from 54% to 23%. And effective tax rate is federal tax, state, local tax, consumption tax, everything. And for the bottom 50%, the tax rate went up, so that the richest 400 have a lower tax rate than any other income group. If you had an approach to justice, to equity, would you do this? And in the UK, the reduction in public spending was sharply regressive. This is spending per person by local government by levels of deprivation. So in the least deprived 20%, look at overall spending, it went down by 16%. And then the more deprived the area, the greater the reduction. So in the most deprived 20%, spending went down by 32%. Neatly regressive. The greater the need, the greater the reduction in spending. Child poverty, before and after housing costs. After housing costs, child poverty is defined as less than 60% median income, went up from 27% to 30%. That is a political decision to increase child poverty. I've just been looking at, it's not UNESCO, it's UNICEF, forgive my error, report card 16, 2020, looking at 38 rich countries. The top 5, Netherlands, Denmark, Norway, Switzerland, Finland, they're in the top third of the rankings on 3 measures: mental well-being, physical health, and skills. The UK ranks 27 out of 38. The USA ranks 36 out of 38. Surely how we treat our children is a marker of the health of our society. And the UK is not looking very good, and the US is looking dreadful. And that loosely correlated with child poverty. Again, child poverty is defined as below 60% of median income. So here's Denmark and Finland, child poverty at 11%. The Netherlands and Norway, child poverty at 13%. Switzerland's a bit of an outlier. That was the 5th good country at 19%. But Switzerland is a very rich country. So being less than 60% median in Switzerland isn't quite so bad. Our 2 not so good countries, UK, child poverty 24%, US 30%. I used to say that US child poverty was nearly as high as Mexico. Actually, it's higher than Mexico now. And Israel, Romania, and Turkey with higher rates. So you can see the political decision to have high rates of child poverty is leading to poor child outcomes. And we know it's not just taxation. This is low and high incomes in the US from Piketty's second mega volume, Capital and Ideology. Average income of the bottom 50% really hardly changed from 1970 to 2015. In fact, it went down from 2008, hardly changed over that 45-year period. And in the 1980s, the average income of the top 1%, wow. Well, there must be a good reason for that. Maybe it leads to better economic productivity. Well, no, it doesn't actually. Here's labor productivity in the United States and in Germany and France, which did not have that big increase in income inequality. And there's no difference. You can get high levels of labor productivity without these massive inequalities in income. Britain lags somewhat behind. And COVID-19, it's the great leveler, isn't it? You must be joking. From March to September 2020, America's 643 billionaires increased their wealth by 29%. That's $845 billion. At the same time, the hourly wages of the bottom 82% of the workforce declined by 4.4%. The pandemic exposes the underlying inequalities in society and amplifies them. This Social Progress Index was published 2 weeks ago, and I've looked at 2 of their 16 indicators. One is inclusiveness. Germany famously handled the COVID-19 pandemic very well. The USA was a disaster, as has been Brazil. If we look at social progress on this measure of inclusiveness, Germany is high and little change. The US, lower than Germany. It wasn't back here in 2011, but lower than Germany. And then it went down between 2016 and 2017. I can't think for a moment what could have happened in the US in that time, and declined further. And Brazil went down disastrously. Personal safety, another of the social progress indices, Germany high and unchanged. The US went down after January the 20th, 2017, and Brazil lower and declined. This is not even correlation, let alone causation, but I'm speculating that this lack of social progress may indeed relate to how badly countries handled the pandemic. Let me finish by saying, what do we do as we come out of the pandemic? A well-being approach can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Where might I have got that from? Amartya Sen? Possibly, but no, I got it from the New Zealand Ministry of Finance. As we come out of this pandemic, we should put this at the heart of what we're trying to achieve, a well-being approach, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Thank you.
Thank you very much indeed, Sir Michael. A lot of food for thought based on solid epidemiological evidence, and it's extremely valuable. I see there are lots of questions. We have a sizable side of the audience who are actually from sub-Saharan Africa, and they have noticed to me privately, where are our indices? And I think we can well see where their indices are, and perhaps at a future session, we should, the unequal world, does not even have those people as part of the indices. It's a great pleasure now to invite our next speaker, Professor Teresa Murphy, who's Director of Health and Human Rights Unit and Professor of Law at Queen's University of Belfast, a significant scholar in terms of human rights. She's co-founder of the Human Rights Preparedness and Initiative of the Global Campus on Human Rights, where she's actively also very, very active. And she's also currently on the National UK Moral and Ethical Advisory Committee, advising the chief medical officers and the UK government around moral and ethical issues around COVID and related issues. And hopefully in the future, we can have a session around learning from that experience. Thank you very much, Professor Murphy. I give that floor to you. Thank you.
Thank you, Farhang, for the kind introduction. Thank you to the keynote speakers for the inspiring start to this session. And hello to everyone joining us. I'm going to begin with the title of this short presentation. The title I chose was Health Justice, the Global and Me. Now, some of you may have been thinking that the title is attention-seeking, showy in a bad way. But as it happens, I do want to talk about myself. Everything I'm going to say today is personal. Everything I say will come from my experience as a professor of human rights law. That's what I mean when I reference me in the title. So what is it that I want to say? Two things. First, I want to make a proposal. And second, I want to explain what led me to this proposal. Here's the proposal. We need to kickstart a new science. The science of asking good questions of and about law. Now, if you prefer art to science, that's okay. It's not going to trouble my proposal too much. You can simply say you're kickstarting a new art of asking good questions of and about law. So whether you are calling it science or an art, the aim will be the same. The aim will be to forge the ability to ask good questions of and about law. And as a shorthand, I'm going to call that ability legal literacy. So that's my proposal, that lawyers and non-lawyers alike who are committed to health justice need to forge legal literacy. That's missing at present. So what led me to this proposal? This encouragement that together we forge legal literacy. Overall, it was a feeling that the legal field, and in particular the human rights law field, is widely misrepresented, both by health justice advocates and practitioners who have non-law expertise, and frankly, very often by people like me, by people who are law's insiders. Both groups, in my experience, tend to misrepresent the legal field. And that's my view for three different reasons. So I can break down my overall feeling about widespread misrepresentation of the legal field into three dimensions. Here they are. First, there is too much general talk and correspondingly too little evidence-based talk about the power of law. I'm certain that law does have power when it comes to health justice. For example, I very much like the idea of the legal determinants of health, which was proposed very recently by the Lancet O'Neill Commission. I find that a compelling idea. I also think there's clear evidence of the ways in which human rights in general and human rights law in particular have changed for the better. How we think about issues such as maternal mortality and the HIV/AIDS pandemic. Yet, too often, too many of us simply assert or assume the power of law. Especially, I think, if we have legal training. But law's capacity, that's what law can or should do, and equally what can or should be done in another way, that capacity cannot be understood simply by invoking law's power or by listing apparent examples of it. We have to understand pathways to power, to the power of law. Second, there is a tendency both to believe and to articulate very damning things about law and lawyers. In crises like COVID-19, many look to law to fill particular voids. But in my experience on a day-to-day basis, public health professionals will often groan at the prospect of more law or having to meet the lawyers. Public health professionals often tell me they feel either daunted or dispirited when they have to meet the lawyers. And to be honest, I also sense a degree of disdain, especially when they tell me that their feelings of obligation keep increasing, but not in a good way, because they simply find their desire to do the right thing trapped in a web of rules, an ever-growing web of rules, both legal and non-legal, which in many cases they find interferes with their desire to do the right thing. Public health professionals often say to me, why is it so hard to understand and be understood by lawyers? Why is it so hard even to ask questions? Questions that are not designed to undermine law, but to test its capacity, its value in particular contexts, to understand what would forge better law and thus better societal outcomes. Third, and finally, I often find that law's capacity is boxed in by our ways of speaking, specifically by the colloquialisms many of us use. By this, I mean our tendency to refer to law and ethics, law and justice, law and governance, law and rights, or for example, ethical, social, and legal implications. We like to run different things together, to put them into connection or relationship with one another. That's of course important, but the risk is that we fail as a result to understand those connections, where they work and where they don't. More specifically, we fail to understand law's place in health justice. So our colloquialisms, like law, justice, rights, law, ethics, justice, rights, law, ethics, justice, rights, and governance, in my opinion, very often they elide difference and they actually block connections. They block solidarity. And very often, as a general rule, they push law downstream to a place where it becomes little more than a technical tool that might be able to capture the important thinking that's been done by others, and where law becomes focused almost exclusively on its capacity, its alleged capacity to prohibit things, which means we exclude unnecessarily law's enabling capacity. So, to sum up, my proposal is that we kickstart a new expertise, the science or art of asking good questions of and about law. This isn't about putting law on top. It's not about having your favorite lawyer on tap. It's not about more law. It's about understanding law's capacity to improve societal outcomes around health. We need, I believe, to build legal literacy. That's what would help to align law and public health towards building more just societies. Thank you.
Thank you very much indeed, Teresa. This is a very important conversation which we are now having, because one of the main purposes of these series is to build partnerships between ethicists, lawyers, public health people, and other health professionals, so to speak. And I think what you've said is extremely important, to build that partnership so we can make real change and not work in our little academic echo chambers or in silos. Thank you very much indeed, Teresa. That's extremely helpful. And I'm sure there are lots and lots of questions being generated, and you're probably being asked to go to Timbuktu to do some training program with them at the moment. I'd like to now invite Professor Maya Groff, who is an international lawyer at The Hague, where she's been working on legal and global treaties for the past 25 years or so. And I think it's important in this initial session, we need to engage different stakeholders as part of this conversation. And her work in The Hague and her expertise is particularly interested. She won the New Shape Prize of the Global Challenges Foundations in Stockholm in 2018. And particularly this particular year, the 75th anniversary of the UN, they published a book based on their research and their prize called Global Governance and the Emergence of Global Institutions for the 21st Century. And we've had conversations with the Global Forum around collaborating with us in public health globally, around looking at the link between local, national, international institutions around health and working collaboratively. So it's a great pleasure to invite Professor Groff to us to share some initial insights around this issue. Thank you, Maya.
Thank you so much, Farhang, and hello, everybody. It's really lovely to be here with you today. And just as a quick disclaimer, I'm speaking today in my individual capacity and not on behalf of any international organization. So I first wanted to really congratulate the organizers on this initiative, both with this multidisciplinary, multi-stakeholder dialogue, but also on the substantive framing of this series on public health, ethics, law, and the future of humanity, at a time when I think in our collective history, there really needs to be this higher level dialogue. This window of time we have now is really crucial. And so I will be today just very briefly zooming out and trying to share some macro perspectives from a broad global governance and health perspective. So as you all probably know, it has been argued that we're now living in a new geological or planetary era of the Anthropocene based on the levels of human planetary influence. And if this is actually correct and true, and this new diagnosed reality presents huge questions about justice, solidarity, public health, that I think we're only just beginning to grapple with and get our heads around. So the notion of an Anthropocene epoch demands really unprecedented levels of collective responsibility for global commons. And this means that at the global governance level, we're going to have to very likely think in different paradigms, that our current systems really have to progress and evolve. And of course, we are at this very moment living in dramatic and uncertain times with the global pandemic, which is driving our thinking inevitably about global risks. We're really feeling it tangibly, what happens when we don't actively manage global risks that we knew were going to be arising. And of course, it's also forcing our thinking about interdependent global risks, which I would say is part of a whole global governance ethical matrix. At the moment, given our current global governance architecture, humanity is really insufficiently protected against a matrix of global risks. And we really have to get our heads around that and grapple with that. So with the COVID-19 pandemic, we see, of course, the pandemic response, which is so challenging at the national, regional, international level, which has, in turn raised issues about our general robustness of public health systems, access to health, the environmental linkages, the economic shocks, the psychological shocks that were described, and also even peace, security, and geopolitical dynamics, which are exacerbated and interplay with managing the global pandemic. So as it has shown, really there is a danger of thinking in silos, and we do need unifying narrative approaches in order to think together on feasible and effective solutions. So a main point I want to highlight today is our current unreasonably and very generous tolerance of global risk across a range of areas, which has been enabled by a lack of sustained and cooperative action by the international community and a lack of sufficient strengthening of our international institutional architecture. Farhang mentioned that it's the UN 75th anniversary, and the basic architecture of the UN Charter has remained unchanged for the last 75 years, even though in the Charter it was negotiated that it should be really revised and rethought within 10 years of adoption. And this was by design based on power dynamics among states, which we're seeing also now play out at institutions like the WHO. So I would say that we're currently stuck at the same point that we've been at over the past number of decades. It's a point that Princeton political scientist Anne-Marie Slaughter described almost 2 decades ago as the globalization paradox. We need more global governance, yet we fear it. And we're now, with this retrenchment against multilateralism, we're seeing the international order even more threatened. So some of you might be familiar with the Bulletin of Atomic Scientists and their doomsday clock, which this year in 2020, they set at 100 seconds to midnight, closer than ever to international catastrophe. And they noted what they see as the key dimensions of the collective threat landscape. So I quote, humanity continues to face 2 simultaneous existential dangers, nuclear war and climate change. This was before the pandemic really hit, that are compounded by a threat multiplier, cyber-enabled information warfare that undercuts society's ability to respond. The international security situation is dire, not just because the threats exist, but because world leaders have allowed the international political infrastructure for managing them to erode, end quote. So again, this is about real political decisions that governments and states are making. So of course, interrelated very fundamentally and deeply to global public health on the ecological front, we know that according to recent and ever evolving, improving planetary science, we are already encroaching into danger zones across a range of planetary boundaries. And there's been new reports that 9 out of 15 global ecological commons tipping points are showing symptoms of being unstable, which puts us all at a very dangerous Earth system point. This week, there's a new UN report on the global biodiversity management front, saying that the world has failed to meet a single target to stem the destruction of wildlife and life-sustaining ecosystems in the last decade. On the climate change front, despite the extraordinary success really of negotiating the Paris Agreement in 2015, Climate Tracker has reported that based on national policy action to date, we have a 97% chance of overshooting the upper 2-degree centigrade limit of the Paris Agreement, putting us in this very serious climate danger zone with difficult and uncertain consequences. And then, of course, COVID-19 has thrown up further challenges for the international community in pursuing vigorous climate action. And 2020 was supposed to be a super year of climate action. So unfortunately, these outcomes are quite predictable due to our weak global governance regimes as agreed to by states. And in terms of steps forward in increasing the quality and effectiveness of global governance regimes, the international community generally throughout history has a pattern of learning from great catastrophes before designing the next generation of international institutions. So of course, this is not the ideal approach in any case. We see with this pandemic, the trillions of dollars of economic damage being set back so much on our global poverty eradication goals, the terrible health consequences, et cetera. But now also in terms of climate and environment, we're risking irreversible effects where there's a lag also in the effects seen, for example, from current emissions. We won't really see the whole set of consequences for decades or centuries to come. And under international law, there is a precautionary principle that is supposed to be upheld to prevent environmental risk and to be very cautious, but this is indeed really not the case with our collective behavior. So that's the news on the bad news side. On the good news side, we do have quite extraordinary norms and principles at this moment, agreed and adopted in a virtually unanimous way, like the Sustainable Development Goals, like the Paris Agreement. But we really don't yet have the global institutional support and the architecture to implement and to realize these agreed international principles and obligations. And so as Farhang mentioned, I've co-authored with two other economists and ecologists a book, Global Governance and the Emergence of Global Institutions for the 21st Century with Cambridge University Press. And I show it to you also because it's available on open access online, because we really wanted to trigger and facilitate broad-ranging consultations on where we're really at in terms of global governance and global risk. So the question now is really, how can we move forward together in a collaborative way to engineer the next generation of fair and effective global institutions? We've heard today a little bit about the problems with the WHO, but this is of course across the range of global institutions. And on the occasion of UN 75, there are some very, again, positive signs. There's a lot of good rhetoric about the commitment to the multilateralism. And also we have, for example, progressive so-called middle power states like Germany and France leading an alliance for multilateralism. So I would just end and argue that we might have an opportunity now for a more decentralized leadership, coalitions, so-called smart coalitions of progressive, middle-powered, progressive states that can work around some of these very unhelpful geopolitical trends to put an enlarged concept of human security and human well-being really at the core, at the center of a new global governance architecture, which we so badly need. So I'll end there. Thank you very much, Farhang.
Thank you very much indeed, Maya. That's extremely helpful. And this initial session, we're touching on lots of issues, and hopefully in future seminars, we can actually go into detail and develop some actions around this one. It's a great pleasure now to to invite our final speaker, Dr. Sridhar Venkataram, who is a professor of global law and philosophy at King's College London. He's also honorary member of our faculty of public health. He actually leads a global group of philosophers called the Independent Resource Group for Global Health Justice, of philosophers around the world who are talking about justice. But he's not just developing the philosophy, he's very much been an activist. In the foreword of his book on health justice and argument for capabilities, which was published some years ago now, Professor Marmot wrote the foreword actually. And I was interested in his foreword. He commented how ethicists often work in an abstract sort of way and talk of distant islands, and they are in little silos in their little world, and he wished there would be more partnership around that one, lamenting their abstract talking. But I'm delighted now Sridhar and Professor Marmot are on the same platform, trying to advance this partnership and this conversation so it can lead to real action. And I know that they're both activists. Thank you very much, Sridhar. The floor is yours. Thank you.
Thank you very much, Farhang. Thank you very much for this invitation and all of you for attending. I especially want to say thank you to all of those public health professionals who are taking time out today in order to attend this meeting. And I hope that your intent is not just, I want to hear something interesting, but what can I use in order to do my work differently, or what can I use to think differently? And I think that's really what I hope to do, and what I would like to do within the next really 8 to 10 minutes, is that I've been asked to talk about two things. One is, what does ethics do for public health professionals? What is this concept of solidarity that everybody is talking about? And what does it actually mean for translating this highfalutin philosophy and abstract ethics stuff to sort of daily practice? And so with that goal in mind, I want to talk to you about three things. One is that I'd like to just tell you about my observations of how ethics has or has not had a role in the last 6 months in this COVID response. Talk to you a little bit about the conception of solidarity and what that's going on and how we can use it. And lastly, talk to you about your daily practice in public health and what I've seen and what I think would be great to think about. The first thing is that in terms of the role that public ethics has played in this COVID response, there is, I guess the analogy that I can sort of draw is that essentially every time in the past we've been trying to incorporate justice, what we've tried to do is expand the scope of our focus and our understanding. So every conversation today has been about how do we expand that scope away from a narrow focus on the wrong things or too small of a narrow focus. So when we talk about equity, we talk about expanding it. When we talk about social determinants, we talk about expanding it. And what this COVID pandemic has done is absolutely narrow all those sort of hard gains about helping us think bigger, broader, more comprehensively. And it actually has made it much, much more narrower. And I'll explain to you what I mean by that. 20 years ago, or more than 20 years ago, when the AIDS pandemic was ravaging, Professor Gostin was one of the leaders in transforming the way that we should be responding to it. And so the initial sort of framing was that there's a minority of people who have this particular disease and the rest of the population is healthy. And how do we contain and control the disease among the minority in order to protect the majority? And Gostin and Jonathan Mann and others said, this is the wrong paradigm. What we want to argue is actually if we protect the basic rights of everybody, then this epidemic will be under control and we're going to have better health for everybody. That health and human rights paradigm has been profoundly influential in my life and also in lots of other places. But what we see in this COVID pandemic is an absolute rejection of that sort of broader understanding. But instead, it's been very much about what are the few versus the many, right? So the absolute sort of modeling and also the policies that have been implemented is about, well, is it okay if a herd immunity policy is allowed to go through because there'll be a fewer number that die, but we'll be able to protect the larger number of people? Oh yes, but you know, if we sort of focus on the majority of the population and protect them, we will have a few and vulnerable groups that are affected, but at least we'll be protecting the majority. That paradigm of saying, actually, we want to be able to look at everybody's health, everybody's got a claim to be protected, and we need to sort of incorporate everyone's interests here, I think has been completely lost by the wayside. This is particularly apparent if you look at the absolute, in the beginning, in January and February in China, when there was an unprecedented quarantine around a city so large, there was not, very few people actually raised the concept of the rights of people in these cities, the effectivity of this kind of quarantine. Is this a reasonable measure to take or not? When the ship, the cruise ship had a variety of different scenarios and people were unsure about the rate of infection, no one asked about what are the different kinds of moral claims of people on the ship, but actually people were talking about sort of where is the ship going to dock. The only time, or the first time, that the ethics question came into being was as the epidemic was spreading and infections were spreading into countries in Europe and the United States, people started worrying about access to ventilators, right? So there wasn't enough ventilators and there weren't enough ICU beds. And so we suddenly have an ethics problem here about distributing limited amount of ventilators. And that has been kind of the first place where people think, oh, this is an ethics question. And then at this point, it was also very clear that I think people like Sir Michael and others were saying, this is not just a problem about limited sort of resources in terms of ventilators. What we see is vulnerability is actually unequally distributed in our population, and we should be implementing policies that try to reduce vulnerability, right? But the focus has always been about trying to expand that sort of focus of policymakers and the debate wider, and it's been a really hard and difficult question. The second thing is that I think one of the most profound sort of narrowing of this conversation in the last 7 months, and which is an ethical and has ethical implications, is that most people have been focusing on the vaccine as being the savior or the end of this pandemic. And for the first 4 or 5 months of this pandemic, there was this emphasis that science will somehow lead us the way out of this. And there was actually a campaign by a leading funder in the UK that says science is the exit strategy. And as time has gone by, what people have realized is that there can be a discovery of new vaccine, there can be new drugs, et cetera, but that may not be enough to solve our problems. But I think anyone, and many of you in the audience, already knew from the beginning that the vaccine isn't the only solution to this, that actually the determinants of vulnerability have to be addressed. And even when you have a vaccine discovery, there's going to be great questions about distribution and access and the long-term impact of it. So there's been a narrowing not only about the ethical focus, but the science that's relevant is actually been narrowing as well. And so we saw a great presentation by Sir Michael about all these scientific data showing you who's vulnerable, what's been happening. But that kind of science has not been welcome and has not been open. And we've not been able to make that part of the conversation. And I think this is not just simply a technical problem. This is a question about social ethics and how different kinds of knowledge is actually allowed and allowed to enter the debate, and certain kinds of knowledge that isn't allowed. And this is one of the few times in front of an audience of public health specialists that we're able to talk about the social determinants of disease, as opposed to the virus and the biological determinants and the vaccine that's going to solve this problem. And I want us to think about that in terms of our public health expertise and how much of our knowledge is actually being made use of, and which of our sciences are actually allowed to inform policies and which are not. The second thing that I've been asked to talk about is this concept of solidarity. Many of us have been using this word, and you've been using, I think you've been hearing it from also the Director General of the WHO and other people. But the real worry here as an ethicist and philosopher is that people are using the concept of solidarity in any which way they want, or they actually don't have a fully thought out sort of concept of solidarity. This is not a problem for me if I was just doing politics, or it wouldn't be a problem in general if we were sort of moral, we were just having a discussion. But what it does is that if we push that concept forward and there isn't a clear concept behind it, then you lose confidence in that concept, and that concept actually loses its value. And this is true. Many people have been talking about, whether we talk about human rights or solidarity or justice, is that if we don't actually have a solid understanding behind it, then that concept and that language becomes less valuable and less trustworthy. So solidarity for a lot of people means cooperation, and that is one concept of solidarity. Solidarity means for a lot of people to have some sort of relationship with the worst off than themselves, that somehow you're in solidarity with the weak and the vulnerable. Solidarity for people means across differences, that you want to be able to somehow connect with people across different kinds of inequalities, social and cultural differences. I think that we have a much, much more powerful concept of solidarity in public health that we are not using enough, which is what anybody who's doing social epidemiology and Sir Michael has been arguing for decades, which is that we as societies cause and distribute disease and illness amongst ourselves in the way that we relate to each other. We also cause and distribute positive health. That's also distributed in various kinds of ways. So the solidarity is not about unequal, it's not about charity, it's not about self-interest. It's the recognition that by living together, we are actually producing and promoting disease as well as health. And so we must be solidaristic in order to ensure that we transform the determinants from being threatening to something that we can mitigate and to be more positive. Lastly, I want to just quickly talk about the real role of ethics in public health. And I've sat on a weekly basis with public health specialists on these epidemiology updates and giving advice. What I've realized is that very rarely do public health people turn to an ethicist and say, oh, we have a problem. And I think this is one of the really big issues at present, is that we as public health scientists and policymakers and practitioners need to be able to acknowledge that there are questions that are uncertain and do not have clear answers. And it is okay to raise those questions and actually have a discussion, not in the scientific realm, but in the ethical realm. And I want to say that there's many people ready to help in those kinds of conversations. And I'll end there.
Thank you very much indeed, Sridhar. Very, very pertinent, and I'm very grateful for you covering all the different pieces of agenda. Just for the people's information, we are going to have specific workshop around meaning of solidarity and implications for practice with our colleagues in Sydney and various other places. So there will be a sort of technical session. I just want to now ask Dr. Frances Butcher, who's a public health physician and also doing a PhD at Ethox in Oxford, what she's been hearing in the chat line and some of the questions which she'd like to sort of ask the panel. Thanks, Frances.
Thanks, Farhang. So we've had loads of really great, insightful questions, which unfortunately we won't have time for all of them. But I've grouped together some of the key themes that have come out. And I'll just give you 3 of these given the time. So the first area was on human rights and disinformation. So there's a question about this. It seems like claims for respecting human rights is being associated with groups that are not willing to comply with COVID-19 measures. And this kind of very narrow narrative is all about my right to do X despite the lockdown. How should we combat this and improve legal and indeed public health literacy? So that's the first question. The second question is around solidarity and in particular degradation of solidarity. So So in the COVID crisis, we're seeing young people blamed for socializing. In the climate crisis, we're seeing older people blamed for their former admissions. And then again in COVID, we see vaccine nationalism, risk reducing solidarity between countries. So in these times of crisis, how can we ensure that we not only engage with new solidarities, but maintain existing ones? And then the third question is a more practical one for all the panel. So this is around bridging disciplines, policy and practice. So there's a lot of thankfulness from participants about these talks bringing together multidisciplinary professionals. But can you name any examples in practice or give any takeaway sound bites to bridge the gaps between public health, legal professionals and ethics professionals, both in academic settings and in practice? So I'll hand back to you, Farhang, because I think that's probably plenty to get on with.
Thank you very much indeed. I don't know the best way we should actually do the questions, because within the chat box, there were hundreds of different questions and from very valued colleagues. And what we'd like to do is actually pull together the questions and do perhaps sessions around some of these. But I think to be fair to members of the panel, I'll give each of them an opportunity to basically talk very, very briefly. And I know they're friends of this particular initiative, and I'm sure we can have conversations in future webinars around these very important issues. So perhaps we start with Larry, then Sir Michael, and then Maya, and then Sridhar in the order of the presentations. If you could basically just, I don't know whether you've had a look at the chat box. One of the questions which I picked up is great to have academic talks and so on. How do we actually turn this into reality also? Because we've got a multidisciplinary audience, which is great, I think. So perhaps Larry, just very briefly, if you want to sort of, talk very briefly around the issues raised.
Sure, and just thank you again, and thank you to all the panelists. It was really a wonderful session. There's so many questions. I think I'll just deal with one of the questions and then let Sir Michael and others that follow answer some of the others. I mean, one of the questions was about from COVID-19's tendency to have the kind of me, my rights ideal. And I've thought a lot about public health and public health ethics. And we began with a kind of an idea of bioethics that really focused very much on the me. What does government owe me as a rights-bearing, autonomous individual? But I think there's another kind of question that had been emerging well before COVID, but certainly reinforced with COVID, is what are my responsibilities to my fellow human being in my family, my neighbors, my community, my state, my world, and that all together as a collective, we have to look out for one another's health, safety, making sure that everyone is treated equitably and justly, including their right to health. And so I think that is really a new striving for public health ethics, and also for law and global governance, is how we can ask everyone to look out for their neighbor, to look out for their community, and for the common global good. That is, I think, COVID for me has highlighted that perhaps more than anything else in the world, that we are indeed all in this together. It's one world, and it's not me against you or my country against your country.
Thank you very much, Larry. Sir Michael,
Let me pick up the question of solidarity that Sridhar talked about. We've had politicians say, well, if we remove the high-risk people, then we're not doing too badly. I've got a great solution for improving the average intelligence of the population. Don't count anybody below the median. And then the average IQ has gone up. It's a brilliant idea. It's totally meaningless. We are connected. And so to say, well, if we didn't count the cities, then COVID-19 wouldn't be so bad, is totally meaningless. The majority of people live in cities. And one of the questions that I saw was to ask me to mention the concept of proportional universalism, which we introduced in my 2010 report. And it was trying to get to put together the idea of a universalist system. We are, as Larry just said, all in this together, which implies universalism. The social gradient implies universalism. If you only focus on people at the bottom, you miss most of the inequalities in health because it's a gradient. Yeah, but what about people at special risk? So trying to put those together, we said we want universalist approaches with effort proportionate to need. So to control the pandemic, exactly as Larry just said, we need a universalist approach, but there are people at special need, the elderly, those with pre-existing conditions and the like, that are special need, and we need special steps. But what we do not want to do is say the rest of you get on with it and we'll do something about the special need group and try and divide society that way. And I would say what happened in the UK, in the early stages, I would like to think that people followed the guidance precisely because they thought they were contributing to the social good. When the guidance became confused, instead of saying stay home to save lives, take care, be careful, don't be silly, it was in a way saying it's up to you, everybody for themselves. And that was a significant loss. That was terrible, would be my guess, that initially we were all doing it for the social good, but that shifted to it's every person for themselves. And that's a very bad way forward.
Thank you very much indeed. I don't know whether, Teresa, you've got unstable, and you said you may not be able to talk. So next, I think, is Maya very briefly, and then Shrida finally.
Yeah, very, very briefly, I very much agree with Professor Gostin's comment about really the need to build global solidarity. And I mean, in our book, we have a whole chapter on global education and values and principles. And we make the argument that this really hasn't happened, in terms of educating on international human rights and this sense of responsibility, even though there are obligations in various international human rights treaties about education of general populations. And just on the information ecosystem integrity, part of what is at play, of course, are these geopolitical forces, which you see mirrored again across the international system that haven't been corrected. So just 2 points that sort of, yes, we have to build this global solidarity, this global civic ethic, and also that these geopolitical forces have to really be thought through and addressed, like the vaccine alliance with WHO. Last I checked, it's the US, China, and Russia that aren't participating. Those are 3 of the permanent members of the Security Council. So anyways, these sort of dysfunctional dynamics are being mirrored at various levels in the international system.
Thank you. Shrida, thank you.
So just quickly, I'm going to just use my 1 minute to say 2 things. One is, I want to thank all of you who are public health practitioners and implementers, to thank you for your work and also for making the time today. The second thing is that I think that this is an opportunity for something that we all intuitively know, but we haven't done very well at, which is to make health as equal as the economics of a country. So in terms of what Sir Michael was saying about how health and health inequalities reflect how well a society is doing, every politician knows what their GDP growth rates are and unemployment rates, but they have no idea basic public health statistics. We haven't done well in actually the public health literacy of our policymakers and politicians and even citizens. And we actually fundamentally have not shown that the economy and the health are equal and interdependent. And this is an opportunity for us to do that. And no one else is going to do it. If public health professionals and people like you don't do it, there isn't anyone else that's going to do it. And so this is really that opportunity to say health has to become more of a visible domain of public policy and public discussion and monitoring on a quarterly basis and on a regular basis. Thank you very much again for the opportunity.
Thanks very much, Sridhar. Thank you very much for all the panelists. This is just beginning of the conversation and the process. Unfortunately, we're just going a minute over the thing, so I just want to have my minute to firstly thank obviously all the panelist members and to basically say this is a webinar series and the purpose is to advance the discourse, scholarship and practice and to strengthen collaboration between professionals, scholars and policymakers. So I hope you will very much continue to be engaged and involved in this journey and process. European Public Association actually through Dinika Ziegler-Paget, who's executive director, has got a particular interest in this, and I want to thank her particular support. She's developed a public health law section, and she's very much been a supporter of this particular initiative. There is a law section now being developed. Similarly, the Faculty of Public Health has got an interest, and the World Federation of Public Health activities. So it's important that these conversations happen within these organizations, not in siloed forms, but collaboratively as part of our education program and so on. So as part of the series, we very much welcome, there'll be a survey sent out after this particular webinar. I very much hope you will share your ideas and collaboration and views on this. There are a couple of big organizations who are already going to take on a number of different seminars around migration, race and public health, obviously ethical legal direction, health research policy and public health policy, politics and health, because a number of colleagues said we should involve our competencies around politics, health security and peace with the European Centers for Peace and Development and various centers, ethical leadership for health, governance, health institutions, sustainable developments. There are also plans to do some master classes and so on this. So please support the work around UFA, Public Health and the World Federation and other associations, so we can have joint conversations rather than academics talking in their own echo chambers and so on. Finally, at the moment, many of you are aware that the World Congress of Public Health is occurring. During this time. This is part of the activities, and we've done it in collaboration with the World Congress. There are 2 World Leadership Dialogue sessions on Public Health Law 2030 Agenda and the Moral Mandate of Public Health, with some of the, with Larry's Marmot and his unit. And there are also significant number of pre-conferences, roundtable discussions, workshop, and join the networks on ethics, law, and human rights. It's essential that these platforms do not just have academics talking to themselves, but rather we engage and do this collaboratively, because as the World Congress statement highlights, we really need to develop one world, one people, and a one health collaborative agenda to get this on board. So I've gone about a minute too overboard because we promised to finish on time. I'd particularly like to thank everybody for joining on this. We had over 850 people who've joined today. We had about 250 people who've actually asked for the recording. So obviously we're capturing a mood, but we need to build on this as a process to learn together, to reflect together, and importantly, to see the implications for policy and practice. And on your behalf, I'd like to thank the panel members who I know are friends of this particular initiative and will continue to collaborate. Thank you very much indeed. Good night, good morning, and good evening all around the world, particularly our friends in Tokyo and Australia who've stayed up all night to watch this. Thank you very much indeed, and see you at our next seminar at the World Congress for other sessions. Thank you very much indeed.
Thank you very much. Bye.